medicine in 1990. He trained at Severance Hospital until now. He's a professor at Joseon University School of Medicine. The title is Cases with Dr. An, please.
Thank you, Chairman. Good evening, ladies and gentlemen. My name is Song from Gwangju, South Korea. Today, I would like to talk about the recent researches of thrombus. Generally, we accept that arterial thrombi are composed of rich platelet, whereas cardiac-originated thrombi are composed of rich blood cell and fibrins. And the target of thrombolytic agent is fibrins. When we decide to use intravenous TPA, we just focus on the salvageable tissue, not thrombi. However, thrombus itself is the main target of repurposition therapy. When I studied the stroke, I imaged the thrombus like this picture. My idea was that well-rounded fibrin pouch and a few white blood cells. However, when I saw this slide at first, I thought that I'm going to be in big trouble. In these photos, can you classify this thrombi into white thrombi and red thrombi? This figure is a histogram of thrombus composition retrieved from 7 patients. The percentage of platelet and red blood cells are not even. We can see the wide range of thrombus components. The middle of this histogram cannot be easily classified into white or red thrombi. So I should find an alternative method to discriminate the thrombi. We know that large artery stroke is similar to coronary artery disease. The start of thrombosis is from the injured vessels under the ruptured plaque. Formed relevant factor and exposed endothelial materials make the platelet adhesion and aggregation. However, those cannot make enough mass. In the next step, activated platelets activates fibrins, which capture the red blood cells in the artery. Finally, thrombi was formed thrombus mass. It looks like a platelet head and red blood cells tails. This patient presented with a right carotid artery occlusion. In the Matthews scarlet stain, figure F, we should focus on the fibrin mesh. Fibrins are stained with red color. Red blood cells, yellow color, are filled in the fibrin mesh. In the CD42 immunostaining, we can see the peripheral distribution of platelets brown, while lateral distribution of platelets was developed. Basically, activated platelets cause fibrins for formation of a firm thrombi. In the stasis environment, platelets distribute more lateral side of vessels and adhere to the endothelium on the vessel. So I found several similar cases in the CD42 immunostaining. A pale blue color indicated red blood cell and fibrin. Platelet color was dark brown color. Had a proximal atherosclerosis. Finally, I could classify it into large artery atherosclerosis type thrombi. In this figure, red arrow indicates white head, initial platelet adhesion and aggregation area. In this figure, you can find the arterial thrombi. Figure A and B are arterial thrombus. In the arterial thrombi, most platelets are located on the outer edge of thrombi, also platelets conjunct with the fibrin shell. This is a unique and distinctive feature of arterial thrombi. The cardiogenic thrombi occurred in the totally different environment. The thrombus can develop and mature as a laminated structure in the stagnant flow. Repeated fibrin platelet-activated coagulation process makes a laminated thrombi. We call the line of Jahn. These patients had been suffered from severe mitral stenosis and atrial fibrillation before stroke event. From the retrieved thrombi, we found the characteristic feature, layered and well-organized structure. The line of Jahn was found in the cardiac chambers because of a chaotic, fast-moving flow. Those thrombi are collected from mostly atrial fibrillation patients. The patterns of platelets were variegated spotted patterns. That platelets also play a major role in cardiogenic thrombi. Contrary to the arterial thrombi, the platelets are cardiogenic. Finally, we can discriminate between cardiogenic and atherogenic thrombi with this immunostaining. Undetermined source. In our study, five of them was spotted pattern platelets. Also, the fraction of thrombus composition is in cardiogenic thrombi. It means that cardiogenic thrombi is developed in a prothrombotic environment. Also, the composition of undetermined etiology cases looks like cardiogenic thrombi. This study examined the relationship between stroke cause and histological clot composition. This triangle graph shows similar distribution of the thrombi components in the group 2 and group 4. Largely, cardiogenic thrombi embolic stroke are composed of large amount of red blood cell. This result is very similar to my result. Another our interesting topic in acute stroke is reperfusion therapy. Fibrin is very important target. Intravenous TPA is based on the fibrin. However, it is not easy to achieve early canalization. Why? In this figure A, we can see a thick fibrin outer shell with platelet lining in atherogenic thrombi. Cardioembolic origin thrombi, figure B, also have fibrin shell structure. However, platelet lining is not found. I suggest that dense fibrin structure may be a barrier of rapid thrombolysis. French researchers are also interested in the structure of acute thrombi. In this figure, we found dense outer shells with scanning electron microscopy. This dense compact fibrin outer shell was composed of fibrins, foam-relevant factors, and aggregated platelets. These components make a decreased susceptibility to. They also reported that acute stroke thrombi share a common remarkable outer shell made of dense compacted thrombus. Its component with a fibrin, foam-relevant factors, and aggregated platelets. They also confirmed our results with a modern technique. The presence of continuous lining of fibrin and platelets at the thrombus periphery, it is a common feature of stroke thrombi. Figure A shows that there was abundant and free. The figure B shows that they try to reveal the effect of ex vivo thrombolysis by a cocktail of TPA and plasminogen. Figure C shows that sensitive to thrombolysis than outer shell. So in summary, outer shell of thrombi is composed of more resistance materials against to the thrombolytic agent. This is another study with the morphological analysis. They are focused on the clot contraction and the association of clinical variables. Clot contraction is the function of platelet-mediated consolidation clot during coagulation process. They found that cerebral thrombi are relatively compact, hardly permeable structures. Also, they suggested that large polyhedral red blood cells are main component. The number 5 in the left figure is a case of polyhedral red blood cell. It means strong platelet-derived clot contraction found that rich polyhedral red blood cells were in our country, cancer is a top cause of death. According to the increased number of cancer patients, now 10% of stroke patients have a cancer. This picture is from a lung analysis. We found that basically cancer stroke is highly correlated with the D-dimer. We commonly accept that cancer is related with hypercoagulability and should be protected with anticoagulants. Shows they did not. Dr. Park and colleagues are interested in stroke patients with cancer. They analyzed the thrombus composition. They wonderfully proved that cancer-related stroke is associated with the platelet-rich thrombi. Cancer-associated stroke may be prevented with an antiplatelet agent. Now, I would like to introduce a case. We did not find any cancer material carotid artery occlusion. After thrombectomy, we collected the white thrombi. The nature of thrombi is not typical. In the histologic analysis, we found atypical mitosis in hematoxylin eosin stain, and the bimentin desmin stain shows positive. Finally, we confirmed that this embolic material is like a stroke with occlusion. In non-contrast CT, hyperdense arterial sign is the result of increased in several angiographic studies. Dr. Kim and Korean colleagues proved that hyperdense arterial sign is associated with a larger volume of thrombi. Also, in addition, I found that the fraction of red blood cell was associated with the hyperdense arterial sign and non-contrast CT. Also, red blood cells was associated with increased mean house period unit and associated with the thrombus volume. Platelets and fibrin shows negative correlation. The fraction of RBC is correlated with the thrombus volume. Only RBC, not fibrin, not WBC, not platelet. Only red blood cells is correlated with thrombus volume. Why thrombus composition is so important in reperfusion therapy? The doctors found that red blood cells percent was associated with a shorter intervention time, and the higher fibrin platelet-rich thrombi require longer intervention time. This simulation figures show that the difference between the fibrin platelet-rich clot and red blood cell-rich clot during aspiration thrombectomy. In the white clot, the 5 French aspiration catheter is not capable of aspirating the whole clot. The major part of thrombus is unprotected and possibly can make distal embolization. In the red clot, the red thrombi is aspirated directly at the occlusion site. In red thrombi, during retraction of stent retriever, the clot is fragmented. When the retriever is pulled back into the balloon-guided catheter, a large part of the clot loses contact with the retriever tip. However, balloon-guided catheter makes flow arrest and can aspirate this part. And also, Dr. Duffy component and intervention procedure. They found that the red blood cell components of thrombus significantly higher in early passages, and the large content of fibrins need more additional procedure trials. So thrombus composition and early regeneration during mechanical thrombectomy is closely related and successful to the thrombi characteristics. In summary, thrombi cannot be simplified into white or red. The large artery type and cardioembolic type thrombi could be discriminated with composition analysis and microscopic picture, even in undetermined source. The histologic analysis of thrombus showed that mechanical thrombectomy could be more reasonable options than intravenous TPA in most cases. Hyperdense artery signs suggest that larger volume thrombi with rich red blood cells. This thrombi composition can affect the regeneration procedure and aspiration catheter or stent retriever.
Thank you, Dr. An. The time is delayed. Just one question from the audience. Interesting presentation. Do you have any clinical data or head-to-head trial for the superiority of antiplatelet over anticoagulant in cancer-associated stroke?
Unfortunately, I have no data from. Well, personally, the antiplatelet agent is more safe because it's controlled. Cancer patients has a lot of problems, such as a lot of pain, excessive pain, and some problems, nutritional problems also. They are suffered from the other problems from the stroke. So I think that the antiplatelet agent is reasonable.
Okay, thank you. So thank you, Dr. An, and thank you.